Dear students, today we are having the next topic of our gastroenterology lecture course in internal medicine, which has the name gallstone disease, chronic cholecystitis, and functional biliary disorders. Bile formed in the hepatic lobules is secreted into the complex network of canaliculi, small bile ducts, and larger bile ducts that run with lymphatics and branches of the portal vein and hepatic artery in portal tract situated between hepatic lobules. These interlobular bile ducts coalesce to form larger septal bile ducts that join to form the right and the left hepatic ducts, which in turn unite to form the common hepatic duct. The common hepatic duct is joined by the cystic duct of the gallbladder to form the common bile duct, which enters to the duodenum, often after joining the male pancreatic ducts through the ampulla of water. Hepatic bile is an isotonic fluid with an electrolyte composition resembling blood plasma. The electrolyte composition of the gallbladder bile differs from that of hepatic bile because most of the inorganic anions, chloride, and bicarbonate have been removed by reabsorption across the gallbladder epithelium. As a result of the water absorption, total solute concentration of the bile increases from 3 to 4 gram by deciliter in hepatic bile to 10 to 15 gram by deciliter in gallbladder bile. Major solute components of the bile by most percent include bile acids, lecithin, and traces of other phospholipids and unesterified cholesterol. In the lithogenic state, the cholesterol value can be as high as from 8 to 10%. Other constituents include conjugated bilirubin, proteins, electrolytes, mucus, and often drugs and their metabolites. The totally basal secretion of hepatic bile is around 600 milliliters. Three mechanisms are important in regulating the bile flow. The first one, effective transport of the bile acids from the hepatocytes into bile caniculi. Second one, active transport of other organic anions. And the third one, cholangiocellular secretion. The last is a secretin-mediated and cyclic AMP-dependent mechanism that results in the secretion of the sodium and bicarbonate-rich fluid into the bile ducts. Cholesterol catabolism by hepatocytes results in the synthesis of two major primary bile acids, cholic acid and xenodeoxycholic acid. This process involves multiple steps, with cholesterol acting as a rate-limiting enzyme. Primary bile acid undergo the hydroxylation by bacteria in the small intestine, forming the secondary bile acid, deoxycholic acid, and lithocholic acid, respectively. Both primary and secondary bile acids are conjugated by liver with amino acid, either glycerin or taurine. Conjugated bile acids are known as the bile salts. Bile salts inhibit cholesterol 7-alpha hydroxylase and decreasing the synthesis of the bile acids. The main steps in the formation of bile are uptake of the bile acids and anions from plasma across the bilateral membrane, transport through the hepatocyte, and excretion via canicular membrane. The sodium-potassium ATPs on the basolateral membrane of the hepatocytes maintain sodium and potassium gradients. Because 3 sodium ions are expelled from the cell in return for receiving 2 potassium ions, an electrochemical gradient is formed. The relative negative charge of basal membrane inside of the hepatocyte favors the uptake of positively charged ions, while the sodium gradient follows the sodium-dependent taurocholate cotransporter protein. This transporter allows for uptake of conjugated bile acids. The transporter proteins found in the canicular membrane are primarily members of ATP-binding cassette protein family. These proteins use active transport to secrete molecules and enzymes into bile. The canicular membrane transporters help secrete molecules into bile against concentration gradients and also enzymes such as alkaline phosphatase. Contractile microfilaments facilitate the secretion of bile through the caniculi. Hematologic organ system also involved in the process of the bile secretion and composition. As bilirubin, the major pigment of the bile, is the end product of metabolism that travels to the liver bind to albumin. Once inside the liver, the enzyme uritin disphosphatase gluconyltransferase conjugates bilirubin to form bilirubin glucuronide. Water-soluble conjugated bilirubin is then secreted into bile, providing its characteristic yellow color. In the livers, which is the site of the bile formation, reuptake of the bile acids, and reuptake of urobilinogen. Bile ducts help to modify and transport bile, secrete ions and water into bile. Gallbladder play a role of the storage and concentrates the bile. Small intestine takes part as bacteria form secondary bile acids via the hydroxylation of the primary bile acids in the lumen of the small intestine. Bilirubin glucuronide is converted back to bilirubin there, and bacteria convert bilirubin to urobilinogen. In duodenum, which is the site of the lipid digestion and absorption, facilitates the bile formation. In ileum, a reabsorption of the bile salts happens. In portal circulation, transport reabsorbed bile salts back to the liver. In the rectum, urobilinogen and stercobilin are responsible for the duct rectal pigment. Some urobilinogen is excreted in the urine. Function of the bile consists from the main two folds. First one to facilitate lipid absorption and digestion, and the second one to eliminate waste products of the body. Through the process of emulsification, bile acids break down large lipid droplets into the smaller ones, increasing the surface area for digestive enzymes. Emulsification is possible due to the amphipathic property of the bile salts. The hydrophilic portion of the bile salts surround the lipid, forcing the lipid to disperse as a negative charge repel each other. Bile salts also allow the products of the lipid digestion to be transported as micelles. The core of the micelle contains monoglycerides, lysolecithin, fatty acids, and the hydrophobic portion of the bile salt. The hydrophilic portion of the bile salts surrounds the lipid core, increasing solubility. Without bile salts, the fat-soluble vitamins as A, D, E, or K cannot be absorbed. Cholesterol is eliminated through its conversion into bile acids, allowing the body to maintain cholesterol homeostasis. Bile acid sequestrants, medication intended to lower cholesterol, function by binding bile acids in the small intestine and increasing their excretion into the stool. Bilirubin is also eliminated through its secretion into bile, where it eventually forms the dark pigment of the feces. There are several types of gallbladder disorders presented here, and let's see their description and definition. Cholelithiasis. It's microscopic crystals or large stone in the gallbladder. If we will observe the term cholelithiasis, you will see that chole presents as the bile part and lithiasis presents as a stone part. So cholit means bile, lithiasis it's stone, so stone in the bile and the site of the bile is gallbladder, that's one. Cholecystitis is inflammation of the bladder, and in the term chole it's part of the gallbladder, and cystitis is acute inflammation of the bladder actually. Choledocholithiasis, common bile duct stones. Choledocho, it's common bile, and chole, it's bile actually, and lithiasis, it's stones. Biliary dyskinesia, it's a motility disorder of the gallbladder caused by scarring or spasm of the sphincter oedi and lead to abnormal passage of the bile due to problem with the normal kinesis or motility of the actually bile ducts. Gallbladder perforation, a hole or an opening in the wall of the gallbladder, can be acute and can be chronic. Also can be some acute in case, for example, acute plus pericholecystitis abscess happens. Gallstone pancreatitis happens due to obstruction of the pancreatic duct by a gallstone, or the common duct by a gallstone. Gallbladder polyps is overgrowth or lesion of the gallbladder wall. Cholecystitis is defined as inflammation of the gallbladder that occurs mostly because of an obstruction of the cystic duct from the cholelithiasis. 90% of cases involve stones of the gallbladder, and 10% cases presented as acalculous cholecystitis. Gallstone disease is very common, and about 10 to 20% of the world population will develop gallstones at some point in their life, and about 80% of them are asymptomatic. Cholecystitis we can divide into acute and chronic one, calculous and acalculous one. So acute cholecystitis is acute inflammation of the gallbladder wall, usually follows obstruction of the cystic duct by a stone. Inflammatory response can be evoked by three factors: mechanical inflammation produced by increased intraluminal pressure and distension with resulting ischemia of the gallbladder mucosa and the wall; chemical inflammation caused by a release of lecithin due to the action of phospholipase on the lecithin and bile and other local tissue factors; and bacterial inflammation, which may play a role in around more than 50% of patients with acute cholecystitis; and chronic cholecystitis, which is chronic inflammation of the gallbladder wall and is almost usually associated with the presence of the gallstones, and is sought to result from repair bouts of the subacute or acute cholecystitis, or from persistent mechanical irritation of the gallbladder wall by gallstones. The presence of bacteria in the bile occurs in the quarter of patients with chronic cholecystitis. The presence of infected bile in a patient with chronic cholecystitis undergoing elective cholecystectomy probably adds little to operative risk. May be asymptomatic for years, which may progress to symptomatic gallbladder disease or to acute cholecystitis, or may present with complication. In case of acute cholecystitis, as we already mentioned, usually the stone in their or common duct or cystic duct leads to retention of the bile inside of the gallbladder, distension of gallbladder, viscosity of the bile, and increased activity on the bacteria or protozoa inside of the gallbladder, which leads to inflammative changes of the gallbladder wall, distension of the gallbladder, and appearance of the pain due to inflammation and possible distension. In chronic cholecystitis, as you can see, usually gallbladder already present, or patient have, for example, chronic inflammation, changes of the gallbladder wall due to bad treatment of acute cases, or hypertonic different motility disorders, which leads to concentration of the bile inside of the gallbladder and formation of the gallstones, and increased risk of bacterial infection inside of the gallbladder. Chronic cholecystitis mostly occurs in the setting of cholelithiasis, as we mentioned, and the proposed etiology is recurrent episodes of acute cholecystitis or chronic irritation from the gallstones. Sometimes the term is used to describe abdominal wall resulting from dysfunction of the emptying of the gallbladder, hypotonic disorders. Or hypomotility disorders, which overlaps with the sphincter of Oddi dysfunction and is the best referred to as biliary or gallbladder dyskinesia. Risk factors for cholecystitis include female gender, obesity, rapid weight loss, pregnancy, advanced age, and some of areas of living as Hispanic or Pima Indians, for example, people. Morphology of chronic cholecystitis consists from or normal or distant, actually, but usually thick wall. Sometimes may be thin, depending on activity of inflammation, presence of absence of different motility disorders. Smooth or shiny serosum, which may be dull or thin. Stones may be seen in majority of the cases, and reflection of the differences in degree of inflammation and fibrosis. Also, more long-term actually course of chronic inflammation is more visible and symptomatic will be chronic cholecystitis. Microscopically, the following features is present. It's predominantly usually mononuclear cell infiltrates in lamina propria, fibrosis or metaplastic changes, Rokitansky-Ash of sinus appearance, portion of the mucosal epithelium through the wall of the gallbladder. Gallstone by causing intermittent obstruction of the bile flow, most commonly blocking the cystic duct and with inflammation and edema of the gallbladder wall. Occlusion of the common bile ducts, such as neoplasm or strictures, can also lead to stasis of the bile flow, causing gallstone formation and resulting in chronic cholecystitis. It has been proposed that lithogenic bile leads to increased free radical-mediated damage from hydrophobic bile salts, in association with reduced mucosal protection due to lower levels of prostaglandins E2, results in a continuous inflammatory state. When the cholecystokinin receptors of the smooth muscle are affected, there is an impaired gallbladder contraction that leads to stasis and worsens the permissive environment where lithogenic bile promotes inflammation. There are several types of gallstones presented here in the pictures, and you can see that they are mainly composed of cholesterol that has solidified. Pigments, gallstones, or usually calcified or contain different types of pigments. That's why they are named like that. Stones can be small, of a grain on the sand, or large, even the size of the golf ball, and can even get to encompass the entire cavity of the gallbladder. So cholesterol mostly contains, according to their name, cholesterol. Pigments contain pigment, and there are mixed stones, which is a combination of two previous ones. Cholesterol gallstone, it's around 80% of the gallstones totally, and contain, according to their name, from cholesterol is a major component. Liver cells secrete cholesterol into bile along with the phospholipid in the form of the small spherical membranous bubbles termed unilamellar vesicles. Liver cells also secrete bile salts, which are powerful detergents required for the digestion and absorption of dietary fats. Bile salts in the bile dissolve the unilamellar vesicles to form soluble aggregates called mixed micelles. This happens mainly in the gallbladder, where bile is concentrated by reabsorption of the electrolytes and water. Compared with vesicles, which can hold up to 1 molecule of the cholesterol for every molecule of lecithin, mixed micelles have a lower carrying capacity of cholesterol. If bile contains a relatively high proportion of cholesterol to begin with, then as bile is concentrated, progressive dissolution of the vesicles may lead to a state in which the cholesterol carrying capacity of the micelles and residual vesicles is exceeded. At this point, bile is supersaturated with the cholesterol, and cholesterol monohydrate crystal may form. The main factors that determine whether cholesterol gallstones will form are the amount of cholesterol secreted by liver cells relative to lecithin and bile salts, and the degree of concentration and extent of stasis of the bile in the gallbladder. Bilirubin is a yellow pigment derived from breakdown of the hem, is actively secreted into bile by liver cells. Most of the bilirubin in the bile is in the form of glucuronide conjugates, which are water-soluble and stable, but a small proportion consists of unconjugated bilirubin. Unconjugated bilirubin, like fatty acids, phosphate, carbonate, and other ions, tends to form insoluble precipitates with calcium. Calcium enters bile passively along with the other electrolytes. In situation of high hem turnover, such as chronic hemolysis or cirrhosis, for example, this type of bilirubin may be present in the bile at higher than normal concentrations. Calcium bilirubinate may then crystallize from the solution and eventually form stones. Various oxidation cause the bilirubin precipitates to take on a jet black color, and stone formed in this manner are termed black pigment gallstones. Black pigment gallstones represent around till 20% of the gallstones. Bile is normally sterile, but in some unusual circumstances, it may become colonized with bacteria or protozoa. The bacteria hydrolyze conjugated bilirubin, and the resulting increase of conjugated bilirubin may lead to precipitation of the calcium bilirubinate crystals. Bacteria also hydrolyze lecithin to oralize fatty acids, which also may bind calcium and precipitate from the solution. The resulting concentration have a clay-like consistency and are torn brown pigment stones. Unlike cholesterol or black pigment gallstones, which form almost exclusively in the gallbladder, brown pigment gallstones often form de novo in the bile ducts. Brown pigment gallstones are usually in the United States, but fairly common in some parts of Southeast Asia, possibly related to liver fluke infestation. There also exist mixed gallstones, as we already discussed. Cholesterol gallstones may become colonized with bacteria and can elicit gallbladder mucosal inflammation. Lytic enzymes from the bacteria and leukocytes hydrolyze bilirubin conjugates and fatty acids. As a result, over time, cholesterol stone may accumulate a substantial proportion of the calcium bilirubinate and other calcium salts, producing mixed gallstones. Large gallstones develop a surface rim of the calcium resembling an eggshell that may be visible on the plain X-ray films. Symptomatic patient with chronic cholecystitis usually present with a dull right upper abdominal pain that radiates around the waist to the mid-back or right scapular tip. The pain may be exacerbated by the fatty food intake, but the classical postprandial pain of acute cholecystitis is less common. Nausea and occasional vomiting also accompany complaints of increased bloating and flatulence. Often the symptom occurs in the evening or at night. Symptoms are usually present over weeks to months and opposite to the abrupt. Severe presentation of acute cholecystitis. There might be gradual worsening of the symptoms or an increase in the frequency of episodes. Fever and tachycardia are rare. Elderly patients with cholecystitis may present with dark symptoms and they are at risk of progression to the complicated disease. Hence, a high index of clinical suspicion is required in the diagnosis of this condition. Gallstone disease may be thought as having the following stages. First one, lithogenic state, in which condition favor gallstone formation. Then symptomatic gallstones. Then symptomatic gallstones characterized usually by episodes of biliary colic and complicated cholelithiasis. Symptom and complication of the gallstone disease result from effects occurring within the gallbladder or from stones that escape the gallbladder to lodge in the common bile duct. Asymptomatic gallstones can be present in case of patient for decades without causing any symptoms or complication. In patients with asymptomatic gallstones discovered it accidentally and likelihood or developing symptoms or complications is like 2% per year, which is really rare. In most cases, asymptomatic gallstones do not require any treatment except maybe the advice of some diet to not increase quantity and actually the size of gallstone. In case a patient has a symptomatic gallbladder disease, it can be in form of the biliary colic usually. In this situation, pain-term biliary colic occurs when gallstone or sludge fortuitously impact in the cystic duct during gallbladder contraction, increasing gallbladder wall tension. In most cases, the pain resolves over 30 to 90 minutes as the gallbladder relaxes and the obstruction is relieved. Episodes of the biliary colic are sporadic and unpredictable. The patient localizes the pain to the epigastrium or the right upper quadrant and may describe radiation to the right scapular tip. It's a common sign. The pain begins postprandially, usually within an hour after a fatty meal, and is often described as intense and dull and may last from 1 to 5 hours. For months, the pain increases steadily over about 10 to 20 minutes and then gradually wanes when the gallbladder stops contracting and stones fall back into the gallbladder. The pain is constant in nature and is not relieved by emesis, anti-cystification, flatus, or positional change. It may be accompanied by diaphoresis, nausea, or vomiting. Other symptoms often associated with choledocholithiasis include indigestion, dyspepsia, belching, bloating, and fat intolerance. However, there are very non-specific and occur in similar frequencies in individuals with or without gallstones. Cholecystectomy has not been shown to improve the symptoms at all and should not be the first step of the treatment of such patients. But it's very important to distinguish uncomplicated biliary colic from acute cholecystitis or other complication. Key findings that may be noted include the following. In case of uncomplicated biliary colic, pain is poorly localized and visceral and essentially benign abdominal examination without rebound or gardening of the abdominal wall. And usually it's the absence of fever. In case of acute cholecystitis or some complications of chronic cholecystitis, well-localized pain usually can be observed in the right upper quadrant with rebound and gardening of the abdominal wall. Positive Murphy sign, which is non-specific, frequent presence of fever, absence of peritoneal signs. The patient has no severe complication, as for example, gangrene of gallbladder. Frequent presence of tachycardia and diaphoresis, and in severe cases, absence or hyperactive bowel sounds. Imagining in the case of chronic cholecystitis can help to differentiate calculus from calculus cholecystitis and complicated from non-complicated cholecystitis and make differential diagnosis between similar pathology, actually gastrointestinal pathology with possible similar symptoms. Abdominal radiography, upright or supine, used primarily to exclude other causes of abdominal pain. Black pigment or mixed gallstones may contain sufficient calcium and appear radiopaque on the plain films, meaning you can see them despite they are not pigment or mixed stones. The finding of air in the bile ducts on plain films may indicate development of choledochoenteric fistula or ascending cholangitis with gas-forming organism. Calcification in the gallbladder wall is indicative for severe chronic cholecystitis. They call the situation a porcelain gallbladder, and you will see on the next picture how it looks like. The main role of the plain films is evaluating patients with suspected gallstone disease, and due to urgent need or not urgent, but need to exclude other causes of acute abdominal pain, such as obstruction, perforation, renal stones, and chronic specific pancreatitis. Some diagnostic advantages of this imagining is a low cost and readily available, especially if patient has some salts in their stones. Limitation are low yield and contraindicated for pregnant patients. On the picture presented on the slide, you can see a gallstone, which is situated, as you can see, somewhere in the intestine, because this is the liver. And here you can see also gallstones presented in the gallbladder, which is topographically is under the liver edge. Cholecystography is used to, in case of if you suspect that patient has chronic cholecystitis, and the following symptoms are characteristic for patients with chronic cholecystitis. They are absence of gallbladder shadow, the arrangements of, in case of its blockage of the stone, or maybe tumor and other one. Causes the arrangements of concentration, ability, and motility of the gallbladder due to delayed emptying as etiological cause of appearance of chronic cholecystitis, and deformation of the gallbladder wall, which leads to actually inability to empty as it should the gallbladder from the bile to. Here presented how it looks like usual presentation of chronic cholecystitis on urine cholecystography. Cholecysto, yeah, it's bile formation, bile carrying formation, and graphy, it's imagined. Ultrasonography is a procedure of choice in suspecting gallbladder or biliary disease, and most sensitive, specific, non-invasive, and inexpensive test for detection of gallstone, changes in the wall of the bladder, functional changes, or deformation of the bladder and the bile ducts. Highly sensitive and specific for gallstone greater than 2 mm and less for macrolithiasis or biliary sludge. Very useful for diagnosing uncomplicated acute cholecystitis. Now features of acute cholecystitis include gallbladder wall thickening more than 5 mm, pericholestic fluid, gallbladder distension, and sonographic Murphy sign. The presence of multiple criteria increases diagnostic accuracy. Endoscopic ultrasonography is very accurate and relatively non-invasive test to identify stones in the distal bile duct system. Diagnostic limitation: bowel gas, massive obesity, hyperstenic people, or ascites. Procedure of choice for detection of the stones due to their positive actually accuracy and sensitivity, and also the cost too. Not limited by jaundice or pregnancy, and may detect very small stones, because 2 meters, that's a lot small. You can see here on the pictures present here that here it's detection of the one, but big stone, and here it's the presence of multiple stones in the form of the sludge near the neck of the gallbladder. Ultrasonographic criteria of inflammation of the gallbladder in case if patient has chronic cholecystitis, calculus 1 is presented on the slide, and there are thickness of the wall more than 4 mm in the absence of the liver and kidney pathology or congestive heart failure. Increase of the gallbladder size over the 5 mm above normal for the corresponding age, which can be a sign of actually gallbladder congestive bile congestive changes, or hypotony of the gallbladder with hypomotility, of course. Presence of sonographic Murphy signs and paracystic hypoechogenic limbus edema of the gallbladder wall due to. Also, in patients with chronic cholecystitis during ultrasonography, you can detect increasing of the size of the wall, increasing of the density of the wall, gallbladder inflammation, or detect a complication if they are present. CT imaging is more expensive, less sensitive for detecting stones, but superior for demonstrating stones in the distal bile duct system. Here you can see appearance of the stone inside of the intestine. And on this actually CT, you can see calcification of gallbladder wall due to chronic inflammation, porcelain gallbladder, and in the lumen of the gallbladder you can see gallstone. MRI can be used in the regimen of pancreatography and usually are reserved for cases in which choledocholithiasis is suspected. Scintigraphy is highly accurate for diagnosis of cystic duct obstruction, but more expensive than previously named and not so frequently used in their hospitals. Radioisotope scans are useful too, and chronic cholecystitis may be diagnosed by calculating the percentage of isotope excreted from the gallbladder following the cholecystokinin or after fatty meal. So you can understand in this case you can not only confirm the diagnosis, but also you can understand the current etiology of the chronic cholecystitis in such patient. Positive in this case, it's accurate identification of cystic duct obstruction or simultaneous assessment of the bile ducts. From negative one, it's contraindicated in pregnancy, and cholecystogram of low resolution, and also is contraindicated in serum bilirubin more than 6 to 12 milligram per deciliter. On their scan presented on this slide, you can see that scintigraphy was performed after 4 hours fasting with isotope given intravenously and imaging taken over 1.5 hours. The absence of gallbladder filling precluded fat-rich meal stimulation and gallbladder function assessment. The patient in this case proceeded with cholecystectomy. Histopathology confirmed the diagnosis of chronic acalculous cholecystitis. Endoscopic retrograde cholangiopancreatography, which is the gold standard for making diagnosis of chronic pancreatitis. In case of chronic cholecystitis, usually performed in conjunction with endoscopic retrograde sphincterotomy and gallstone extraction. It's usually the tube of endoscope with special tool which can help the surgeon to make wider the common bile duct and to perform gallstone extraction not only from the bile ducts but also from pancreatic duct stone. On this film you can see the filling defects. Here they are noted in the gallbladder, and if we can see the gallbladder duct but cannot see completely the shadow of the gallbladder due to presence of the stones. And there are other common medical conditions that can mimic the presentation of chronic cholecystitis, and the workup for the patient should The goal of workup of the patient is not only to make diagnosis, but to exclude any other clinical situation that can be similar to it. So common clinical feature of these disorders are follows: acute cholecystitis, usually presented with a continuous severe pain in the right side of the abdomen, lasting for hours, associated with fever, nausea, vomiting. In an ill-looking patient, is suggestive acute cholecystitis. Chronic abdominal symptoms associated with the weight loss or other constitutional symptoms should raise suspicion of gallbladder cancer. Imagining histology helpful to make a definitive diagnosis. The presence of pregastric abdominal pain and early satiety should alert the possibility of peptic ulcer. Alarm symptoms include weight loss, anemia, melena, or dysphagia. Can also help you to exclude or make diagnosis of stomach cancer or complicated peptic ulcer disease. Burning sensation at the epigastrium or retrosternal region may be associated with the regurgitation of the food material in patient with GRD. The presence of alarm symptoms of peptic ulcers, persistent vomiting, evidence of malignancy, or the risk factors should alert the possibility of the gastric cancer. If patient has some palpable masses in area of topography of gallbladder with the symptoms of abdominal pain, weight loss, anemia, also can be a sign of gallbladder cancer or bile duct system cancer. In case of the inferior wall right ventricular ischemia, the presenting symptoms may be epigastric pain with nausea, vomiting, and other chronic symptoms like dizziness or dyspnea, or specters for coronary ischemia should prompt to work up for the myocardial infarction. The acute variant of mesenteric ischemia presents with severe acute abdominal pain, and chronic variant typically with postprandial pain. All that risk factors for atherosclerosis, bottom the stool, and weight loss, and also different type of coagulant disorders concerning features of this condition. Presence of ongoing abdominal walls unexplained by the regular workup, and the presence of other features consistent with vasculitis could be related to this relatively unrecognized but dangerous condition. Treatment of cholecystitis depends on the severity of the condition and the presence or absence of complication. Uncomplicated cases can often be treated in outpatient departments. Antibiotics may be given to manage infections, but only in presence of the signs of bacterial infection, which usually are presence of fever or leukocytosis in the CBC. Treatment in case of exacerbation consists of antibiotics. In case if you confirm the presence of bacterial infection, the CRB and procalcitonin are the markers of this infection and can be helpful in severe cases too. Positive result of the bile culture or presence of cholangitis. In this case, the antibiotics of the choice is ciprofloxacin, cefotaxime, doxycycline, amoxicillin, and tinidazole. Cefotaxime is the antibiotic of choice to prevent possible appearance of peritonitis in patients with gallbladder problems. Symptomatic therapy include prokinetic agents, as for example domperidone, spasmolytics to reduce the pain and decrease of the spasm, which helps to release the stone from the canicular system. Bile expellent medication or halagox group preparation that stimulate colipoetic function of the liver, or other called choleretics, should not be prescribed for patients with calculus, cholecystitis. preparation of the bile acids or synthetic preparation, herbal origin preparation, which can help to destruct stones, especially if they are cholesterol or pigment ones. Of course, if it's calcium stones, you cannot destruct them using the drugs only. Preparation that improves secretion of the bile by increasing of its aqueous component or hydrocoloretics. Mineral water should not be used in patients with calculus cholecystitis, only in acalculus due to different problem with bile elimination from gallbladder. Cholecystitis increases tonus of the gallbladder, increases tonus of the bile ducts, and can help to eliminate the bile from the gallbladder and to prevent inflammation and congestion. Also can be used cholecystitis, especially in patients with increased motility of the gallbladder or in patients with the stones inside of the ductal system. Also, desoxycholic acid can help to decrease or can help to destruct the bile stones if they are not contain calcium salts. Herbal HIDA protectors with the bile expanded properties can be used too. In phase of remission, treatment consists usually from diet modification. It's a meal from 5 to 6 times a day without fatty, fried, spicy, smoked food, pickles, alcohol, coffee, etc. Presence of the phytotherapy usually include with choleretic abilities or cholecystotic if needed. Mineral water, physiotherapy, and exercise therapy to improve motility of the gallbladder and ductal system. In case of gallbladder, gallstones, disease, the treatment will differ from symptomatic and asymptomatic cases. In asymptomatic cases, surgical treatment without medically complicated diseases is discouraged. The risk of complication arising from intervention is higher than the risk of symptomatic disease. Approximately 25% of patients with symptomatic gallstone develop symptoms within 10 years. Cholecystectomy for symptomatic gallstone may be indicated in case if patient has large gallstones greater than 2 centimeters in diameter, patient with non-functional or calcified gallbladder observed on imaginary studies, and high risk of gallbladder carcinoma. Patient with spinal cord injuries on sensory propaedeutics affected abdomen. Patient with sickle cell anemia whom the distinction between painful crisis and cholecystitis may be difficult. Patient with risk factor for complications of the gallstone may be offered elective cholecystectomy, even if they have asymptomatic gallstones. These groups include persons with the following condition and demographics: cirrhosis, portal hypertension, children, transplant candidates, diabetes with minor symptoms. Patient with a calcified porcelain gallbladder should consider elective cholecystectomy due to the possibility of increased risk of carcinoma. A refer to surgeon for removal as an outpatient procedure is possible for such patients. Exists also medical dissolution of the gallstones in patients with established cholesterol gallstones, which can be usually seen during, for example, plain X-ray. They do not contain calcium salts. Treatment with desoxycholic acid is indicated and may result in gradual gallstone dissolution. This intervention typically requires from 6 to 18 months and successfully only with the small, purely cholesterol stones. Patient remains at risk of the gallstone complication until the solution is completed. Recurrence rate around 50% in the first 5 years. Moreover, discontinuation of the treatment in case most patients form new gallstone over the subsequent 5 to 10 years. In case of symptomatic gallstones, you should discuss the options for surgical intervention if needed. Surgical intervention may be considered to include the following: cholecystectomy, open or laparoscopic, cholecystotomy to take the gallstone out, and endoscopic sphincterotomy if needed to gallstoneectomy too. Oral bile acids used for the solution of the gallstones include not only xenodesoxycholic acid and or desoxycholic acid. They are most effective, as we say already in the small gallstone. On the table present in the slide, you can see not only dosages but therapy duration and possible adverse events such as headache, dizziness, diarrhea, hypercholesterolemia, leukopenia, and increased serum, for example, aminotransferase. So before prescription of such medication, you should be sure that patient has small gallstone. They are cholesterol contained without calcium contained, or has only small amounts of calcium, so it's inside of the stones, and patient should be followed up during this 6 to 24 months treatment period constantly. Choledocholithiasis is the presence of the stone within the common bile ducts. Estimated that common bile duct stones are present anywhere from 1 to 2% of the patient with choledocholithiasis. This situation has been found around till 20% of the patients undergoing cholecystectomy. Occurs as a result of either the formation of stones in the common bile duct or the passage of the gallstone that form the gallbladder into common bile duct. Bile stasis, bacteria and the bile. Chemical imbalances, increased bilirubin excretion, pH imbalance, and the formation of the sludge are some of the factors which lead to the formation of these stones. Less commonly, stones are formed in the intrahepatic biliary tree, termed primary hepatolithiasis, where hepato is the liver and lithiasis is the presence of stones, and may lead to choledocholithiasis. Stones that are too large to pass through the ample of the water remain them distal common bile duct, causing obstructive jaundice that may lead to pancreatitis, hepatitis, or cholangitis. Primary canicularizing de novo in the ducts are usually a brown pigment stone developing in the patient with hepatobiliary parasitism or chronic recurrent cholangitis. Congenital abnormalities of the bile duct, for example, Caroli's disease, dilated, sclerosed, or structural ducts. Different genetic defects leads to impaired biliary phospholipid secretion. Common bile duct stone may remain asymptomatic for years and may pass spontaneously into the duodenum, or may present with biliary colic or the complication, depending on which situation. Is more common, choledocholithiasis is more common in female patient, pregnant patient, older one, or patient with high serum lipid levels. Cholesterol stones are typically found in obese patients with low physical activity or patients with that have recently internationally lost weight. Then intentionally, I'm sorry. Black pigment stones are found in patients with cirrhosis, patients receiving total parenteral nutrition, and in those who have undergone the ileal resection. Nucleating factors such as bacteria are the source of the brown pigment primary common bile duct stones. Bile made in the liver and stored in the gallbladder can lead to gallstone formation, and some patients with the gallstones, the stone will pass from gallbladder to cystic duct and then to the common bile duct, and most of choledocholithiasis cases are secondary to the gallstone passage from the gallbladder to the common bile duct. Primary choledocholithiasis, which is the formation of the stone within the common bile duct, is seen less commonly and occurs in the setting of the bile stasis, which result in the stone formation. The size of the bile duct increases with the age, and older adults with dilated bile ducts and biliary diverticula are at risk of the formation of primary bile duct stones. Less common sources of choledocholithiasis include complicated Maritza syndrome or hepatolithiasis. Bile flow is obstructed by stones within the common bile duct, which leads to obstructive jaundice or possibly hepatitis. Stagnant bile can also lead to bacteria and ascending cholangitis. Cholangitis and sepsis are more common in patients with choledocholithiasis than other sources of the bile duct obstruction, because the bacterial biofilm typically covers common bile duct stones. The pancreatic duct joins the common bile duct near the duodenum, and therefore the pancreas may also become inflamed by the obstruction of pancreatic enzymes. Doctors should examine the patient with particular attention to the general appearance, skin, vital signs, and abdomen. Tenderness is noted in the right upper quadrant of the abdomen. Systemic signs such as a fever, hypotension, or flushed skin, if present, is indicative of the infection or sepsis. Courvoisier sign is the presence of palpable gallbladder on the exam, as seen when gallbladder dilation develops due to obstruction of the common bile duct or gallbladder is full of the stones. Or a patient has cancer of the gallbladder, for example, or different type of inflammatory complication of gallbladder disorder, such as gangrene of the gallstone, for example. Or patient may have other disorders of such as, for example, cancer or tumor rather of common bile duct, which leads to retention of the bile, increase of the size of the gallbladder, and inflammation appeared. The pain is colic located on the upper quadrant of the abdomen and moderate in the severity. The intermittent and recurrent. Often, patient will endorse a history of episodes of epigastric right upper quadrant pain or epigastric pain. A thorough review of the symptoms will reveal that the patient may have noticed yellowing of his eyes or skin, experience pruritus, and possibly nausea or vomiting. Jaundice occurs when the stones obstruct the common bile duct and conjugated bilirubin enters the bloodstream. History including clay-colored stool and urine turning tea-colored is found in such patients. Jaundice can occur in episodes, and patients with cholangitis may also have fever, chills, and possibly altered mental status. Gallstones are responsible for approximately half of the cases of pancreatitis, and pancreatitis precipitated by the bile duct obstruction is at the level of the ample of the water. In this case, pain is located in the epigastric columns, abdominal areas, and continuous, comparing with the cholecystitis pain, and radiates to the back. Nausea, vomiting are also present. Some patients have intermittent pain, which results due to transfer blockage with the common bile duct. Doctor should order a white blood cell count, hemoglobin, hematocrit levels, platelet count, total bilirubin, direct bilirubin, alkaline phosphatase, AST, and ALT. In this case, AST, ALT are the markers of the hepatic cell damage due to as one cause of bile retention, or can make differential diagnosis of toxic or viral or other types of hepatitis, or cirrhosis is the possible cause of the symptoms. For example, alkaline phosphatase in case of the patient with the bile system problems. Usually it's a sign of possible obstruction of the Bile ducts and retention of the bile. Direct bilirubin and total bilirubin will help you understand the nature of the jaundice. White blood cell count and changes in can be sign of bacterial infection. In case of hemoglobin hematocrit can help to make differential diagnosis between cancer or different type of jaundice. Such patient. In patients with cholelithiasis, total bilirubin greater than 3 mg by deciliter to 4 mg by deciliter is strongly associated with choledocholithiasis. Gamma glutamyl transpeptidase is also elevated. Serum alanine aminotransferase and aspartate aminotransferase concentration elevated in biliary obstruction in a cholestatic pattern, which increases in alkaline phosphatase. Serum bilirubin and GGT exceeding the elevation in the serum of AST and ALT. Symptom resolution coupled with the downtrending liver function test suggests that the patient has spontaneously passed the gallstone. Transabdominal ultrasound is the first test that should be ordered to the patient suspected in any biliary disease, including choledocholithiasis. Endoscopic ultrasound also can be used to identify suspected choledocholithiasis, but is more invasive than transabdominal ultrasound or MRI. Also, diagnostic endoscopic retrograde cholecystopancreatography is more sensitive, and it's no longer routinely performed, given the approximately 10% of risk of post-procedure pancreatitis. If a patient has undergone laparoscopic open cholecystectomy, intraoperative cholangiogram also can be performed to assess the choledocholithiasis. It's performed by inserting a catheter into the cystic duct and followed by injection of contrast material, which outlines the biliary tree. Films are taken to assess the presence of filling defects, the flow of contrast into the duodenum. Intraoperative ultrasound or laparoscopic ultrasound will also identify choledocholithiasis. Transabdominal ultrasound is the first test that should be ordered for the patient suspect of any biliary disease, including choledocholithiasis. The most cases of this type of ultrasound will show a dilated common bile duct more than 6 mm and stone within the common bile ducts. The detection of common bile duct stone is typically impeded by the presence of gas in the duodenum, but ultrasound can identify dilation of the common bile duct accurately with 9% of accuracy. If strong suspicions still exist based on the history, physical laboratory findings in face of negative ultrasound, then the magnetic resonance cholangiopancreatography can be ordered. The treatment of choledocholithiasis is the removal of obstructing stones via endoscopic means. An endoscopic retrograde cholangiopancreatography can be performed under general anesthesia with the patient either prone, left lateral, supine position. So prone is the most common position used. The endoscopist will then place a duodenoscope into the second portion of the duodenum and advance a catheter and guide wire into the common bile duct. A synchrotome then used to cut the papilla using cautery and enlarge the ampulla of the water. Often the stones will be released with this maneuver. A balloon catheter also can be used to sweep the common bile duct to remove any stones. The endoscopist also can place a stent in the common bile duct if needed, which will serve two purposes. First, any remaining stone will be softened and potentially easier to remove with the second endoscopy. And second, the stent will allow bile drainage to occur, preventing obstructive jaundice. If the stones are large, stuck, or there are many stones within the biliary tree, surgical removal is indicated. There are no medications that will cure choledocholithiasis. However, once-time dose of 50 to 100 mg rectal in the medicine can be used to prevent post-procedure pancreatitis if the pancreatic duct was manipulated during endoscopy procedure. Antibiotics are typically not needed for choledocholithiasis unless the patient also has associated cholecystitis or cholangitis. Cholecystitis usually appears in case of the obstructive stone in the cystic duct, comparing that choledocholithiasis is present of the stone in the common bile duct, and cholangitis is biliary obstruction and affected biliary tract. If patient with cholangitis present mostly with fever, possible jaundice, hypertension, and other systemic symptoms. Patient with choledocholithiasis can be or asymptomatic or can be present without fever, but similar jaundice or pain in their right upper quadrant. Patient with cholecystitis can be present either fever and jaundice in case if it's cholecystitis, or a different type of the pain and Murphy sign too. Treatment if patient has signs of bacterial infection, antibacterial drug should be prescribed. If there is no possibility to actually delete stone from the system without surgical intervention, then surgical intervention should be prescribed. Stone removal in case of choledocholithiasis is essential for treatment and can be used without laparotomy or laparoscopy, only with endoscopic guidance. On the slide, you can see comparative differential table between 4 major conditions, patient with bile disorders, and which can be actually useful for you to prepare for classes and for real life. And let's discuss functional biliary disorders, which is the biliary dyskinesia, and is an enigmatic but important condition to consider in the evaluation of the patient with right upper quadrant pain. As through history, workup and examination are needed, and this diagnosis is primarily a diagnosis of exclusion. Proper selection of the patient for cholecystectomy is essential in order to avoid unnecessary operative intervention. Biliary dyskinesia is the symptomatic functional disorder of the gallbladder whose precise etiology is unknown. It may be due to metabolic disorders that affect the motility of GI tract, including the gallbladder, or to primary alteration in the motility of the gallbladder itself. Biliary dyskinesia presents with a symptom complex which is similar to those with biliary colic, and includes episodes of right upper quadrant pain, severe pain that limits activities of daily living, and nausea associated with episodes of pain. In order to diagnose biliary dyskinesia, the patient should have right upper quadrant pain similar to biliary colic, but have a normal ultrasound examination of the gallbladder. No stones, no sludge, no macrolithiasis, gallbladder wall thickening, or dilation of the common bile duct. For patients who are suspected to have primary biliary dyskinesia, the ROMS 3 diagnostic criteria for functional gallbladder disorder should be considered, and they include pain episodes that last longer than 30 minutes, recurrent symptoms that occurs of variable intervals, pain that is severe enough to interrupt daily activity or lead to visits to emergency room, pain that builds up to a steady level, not relieved by bowel movements, postural drainages, or antacids, exclusion of other structural diseases could explain the symptoms. Other supportive criteria include association of the pain with nausea and vomiting, radiation of the pain to the intrascapular region, the pain that wakes the patient in the middle of the night, normal liver enzymes, conjugated bilirubin, and less lipase levels. If patient meets this criteria and has a normal ultrasound examination, the HIDA scans should be considered. A recently updated criteria for the performance of hepatobiliary scintigraphy or HIDA scan should be followed by determine the gallbladder ejection fraction. These guidelines recommend imagining of cholecystokinin or ostapeptide infusion at a slow and constant rate over the 60 minutes. I also included the important clinical consideration prior to testing, performance of the test only on outpatient basis, status of the patient 4 to 6 hours before testing, no IVth for half-life of the drug or 6 hours prior to the study. Patients should not eat and drugs present on the slide which can affect gallbladder motility should be excluded from the treatment. A hepatobiliary immunodiastatic acid scan or HIDA scan is an imagined procedure used to diagnose problems with the liver, gallbladder, and bile ducts, also known as cholecystoscintigraphy and hepatobiliary scintigraphy. May be done to measure the rate to which the gallbladder releases the bile, commonly referred to as gallbladder ejection fraction. Check the liver bile secretion fraction. Follow the path of the bile from the liver to the small intestine, assess the outcome of the liver transplant. Find the cause of the pain originating in the right side of the abdomen. Uncover the cause of the jaundice for yellowish hue to the skin. HIDA scan can help diagnose the following as biliary atresia, cholecystitis or inflammation of the gallbladder, complication of the operations, several, and obstruction of the bile duct. During procedure, specialists will insert intravenous line in the person's arm and inject radioactive tracer. A technical will position a gamma camera above the person's stomach to capture images, and tracer will move through the IV line to the bloodstream and will travel in the liver. At this stage, bile-making cells of the liver absorb the tracer and carry it through the gallbladder, bile duct, and small intestine. Process takes up to 90 minutes and can take up for 4 hours in some cases. And after images observation, diagnosis can be made. For gallbladder discussion, we have several tests, and the major one is cholecystoscintigraphy assessment of the gallbladder emptying. The study continuously monitors the hepatic excretion of radiopharmaceutical into the gallbladder and duodenum, compared computer systems to quantitate changes in radioactivity of the gallbladder. Emptying of the gallbladder is expressed in this case ejection fraction with percentage decrease in the net of the gallbladder columns following infusion of CCK8. The reduced emptying, which defines gallbladder dysfunction, can arise from either depressed gallbladder contraction or increased resistance, such as elevated tone on the sphincter or the several conditions that do not necessarily present with biliary colic can be associated with reduced gallbladder emptying. These range from intrinsic gallbladder disease to neural or metabolic disorder, drugs, and even irritable bowel syndrome. Transabdominal ultrasonography measures gallbladder volume, which is followed serially after the stimulus reflex emptying, and technically is operator dependent, and result may not be reproducible in the different centers. Ultrasonographic assessment of the gallbladder emptying is currently not the standard for the gallbladder dysfunction evaluation. pain provocation test can duplicate CCKA test and use historical proof previously as diagnostic investigation. Such tests have low sensitivity and specificity in selecting patients with gallbladder dysfunction who respond to the therapy. Patients who have episodes of biliary type right upper quadrant pain without structural abnormalities by ultrasound and abdominal hepatobiliary immunodiastatic acid scan should be considered for cholecystectomy. And abnormal injection fraction is considered to be less than 38% when the test is administered according to the guideline described. Some authors and experts recommend that the symptom complex should also be sufficient duration, at least 3 months before referring patient to the surgeon. Performance of HIDA scan in the absence of the symptom complex outlined above the criteria 3. So patients with typical symptoms who have abnormal HIDA scan will not necessarily benefit from cholecystectomy, and as other etiology are more likely. Failure to adequately exclude other structural diseases that could explain the symptoms, and trial of medical therapy or dietary manipulation should be considered for those thought to have functional bowel motility issues. And thank you for your attention. If you do have any questions, please use our department site and find my email, and I will respond you, of course. So have a nice day and see you during the next lecture. Goodbye.